Thank you for inviting me. It's an honor and a pleasure for me to be here. As you can see, I come from the University Clinic for Hand, Hip and Knee Surgery in Denmark. Before I start my presentation, I will just show you this. This has nothing to do with what I'm going to talk about. But we are about the same area in Denmark and Holland. But you are 3 times as many people in the same place. And maybe that is one of the reasons that you make so many good articles about medical pedagogy down here. I don't know, but I have read many articles written in Holland about medical pedagogy. One more slide before I start my presentation, because 1 year ago there started an obstetric interprofessional training unit in our hospital. And they have similar approach as we have in the orthopedics pedagogic approach. And their patients are families admitted for planned cesarean section. And they have midwives for 2 weeks, nurses for 2 weeks, and medical students for 1 week. And now we come to what I'm invited for. First, terminology and concepts. Due to the fact that the same word can have different meaning to different people, and because some concepts are labeled differently but possess the same meaning, I will give my definition of the cross-professional continuum, which includes multi-professional, interprofessional, and trans-professional. I will start with multi-professional, which is the most normal way of working in hospitals. In this model, members or students of multiple professions learn and work independently and only share information with each other. Then we have the trans-professional part of the continuum. Here all patients work very closely together and share information and also to some degree tasks with each other. There are not so many documented papers about trans-professional collaboration. In the middle we have interprofessional collaboration, where each profession retains its own core competences. There are also overlapping and common competences. An example of a common competence for an occupational therapist and physiotherapist and a medical doctor could be estimation of movement in a finger joint. Multi-professional education and collaboration is the most normal way of working in hospitals. This means that people are closely affiliated to colleagues from their own profession, and this is in itself not a problem, but it may result in lack of communication between the professions, with following risk of mistakes and dysfunctional patient courses. Another consequence of multi-professional organization can be storytelling about the others, and these stories are not always so nice about the others. One important thing in this model is that the bottom line is a continuum, which means that you can move from one end to another. You can move freely on this bottom line. There's not one correct way to be on that. It depends on the situation, how you are working in a given situation, whether you work interprofessional, trans-professional, or multi-professional. It's the same in teaching. When you teach students, you can move on this continuum. The definition of interprofessional collaboration is given by the Center for Advancement of Interprofessional Education. Sounds: interprofessional education occurs when 2 or more professions learn with, from, and about each other to improve collaboration and the quality of care. And that's what it's all about. It's about the quality of care. Interprofessional training unit in Holstebro started in 2004, and the aims are to provide possibility for interprofessional learning, uniprofessional learning, formation of professional identity, and to create a safe and challenging learning environment. We have students from occupational therapy, physiotherapy, medicine, and nursing in periods of 2 weeks, and our patients are admitted for planned scheduled arthroplasty of hip or knee, and we have 8 beds in a ward with around 40 beds in the ward. Staff, we have a superior team of clinical tutors, occupational therapy, physiotherapy, and nursing, and associate professors. They are surgeons. And then we have 4 permanently employed nurses who are willing to and able to work out from the pedagogical principles we want to use in our interprofessional training unit. The pedagogy. Adult learners are motivated by the tasks they identify themselves and perform themselves. In the interprofessional training unit, students are required to identify and perform tasks in accordance with the patient's needs. Our pedagogy is practice-based and authentic. which means again that the patient needs and the description of procedures set the agenda. In other words, the patient comes first and then the student. We emphasize that learning be active, self-directive and collaborative. Active evaluation takes place whenever appropriate during the placement, but summative evaluation of the clinical placement is normally not performed. The 1 hour daily interprofessional morning meeting is a cornerstone in the interprofessional training unit. Students and supervisors are present. The roles for the students are to be in the front, to make decisions, to distribute tasks and to share knowledge. And the role for the clinical tutors are to sit on their hands, it's not so easy, to ask reflective questions, to steer if necessary, and to be aware of their own role. During the placement, students from all professions have to start the presentation of a patient in the meeting. They are supposed to present the patient's name, age, type of operation, post-operative day and comorbidity. Further on, they have to present a short and precise description of the patient's present situation and focus area, including new events since last meeting. The students are urged to keep focus on their own professional tasks and explain their task for the day, including why, how, and when they will perform them. The clinical tutor's role is to be there for the students and for supervising that the patients get the correct care. Being there for the students means that the clinical tutor on the one side have to stand back and let the student do the talking, but on the other side challenge the students by asking reflective questions. Therefore, the clinical tutors sometimes have to change their perspective from listeners and act as teachers. And then it is important for them to be aware of the shift of perspective. And one way of being aware of the shift of perspective is to speak it out so that both the students and the clinical tutor herself can hear it. Here I have a little story about acquisition of interprofessional knowledge and skills, including respect for other professions. The students are here sitting in the interprofessional morning meeting discussing a 45-year-old man who had an arthroplasty of the knee the day before. This man is laying in the bed. He suffers from a fusion of the knee and he has pain and he do not want to get out of the bed. He has a pillow under his knee. That's not so good because it should be straight, and he has his arm up here. And he says he just wants to get home, and he has a 12-year-old son that can take care of him when he comes home. The students do not find this is a good idea, so they agree on letting the medical student and the physiotherapy student go to the patient together and examine him. Here we see them, they are agreeing on their role before they go into the patient. And here the medical student is explaining to the patient what we will do now. And here we see the two professions, the physiotherapy student and the medical student standing and examining the patient's knee. Both of the students demonstrate uniprofessional knowledge and skills by explaining the patient about their considerations and about examining the patient's knee. The students have a common central focus, which is the patient's situation, and right here the problem with the knee. And this central focus creates a base for acquiring interprofessional knowledge and skills because the students share knowledge and supplement each other when examining the knee. What is illustrated here is that the subordinate identity as a physiotherapy and medic respectively coincides well with the superordinate identity as being a member of an interprofessional team. There's another little story about student learnings from each other. Now they are discussing an 83-year-old lady who had an arthroplasty of the hip the day before. She has to be mobilized, but she did not feel well this morning. She suffered from nausea and vertigo. Here are the students together, the physiotherapy student and the nursing student together with their supervisor, and sharing the roles before they go into the patient. The nurse student is measuring the patient's blood pressure, which turned out to be normal. And now the physiotherapy student will guide the patient out of the bed. What we see here is an atmosphere of equality was felt by the student. They were equal in this situation. There were common goals, which here is care and rehabilitation. They collaborated about mobilization of the patient, and they got support in this situation from their clinical tutor. So in the interprofessional training unit, the students gained a better understanding of their own professional role. The occupational therapist could think more widely of what can I offer the patient, more training than just helping aids and training in the bathroom. The nurse could be responsible for dispensing medicine and for a ward with room with several patients. The physiotherapist could see if it was safe to discharge the patient. Can he climb the stairs? Can he manage the exercises? And the medic could take responsibility for independent communication with the patient and for what to dictate for the record. We also let the students teach each other. Here's a physiotherapy student teaching it what is a physiotherapist core task. She could also teach in how to examine strains and range of movement in hip and knee. The medical student could teach in what is included in discharge summary or different types of painkillers. The occupational therapy student could say, let us all try to use these helping aids to get the stockings on. Or she could teach in basic activities or instrumental activities of daily living. The nursing student could teach in what are the requirements in relation to hand hygiene or anaphylactic shock. And now for some results from the interprofessional training unit. The students strengthened their professional identity, their interprofessional knowledge and capabilities, and their uniprofessional knowledge and capabilities. Professional identity included responsibility, independence, identity, better overview over complicated situations, self-efficacy, and to be an acknowledged member of the profession. Interprofessionalism included interprofessional collaboration and knowledge and respect for other professions. And uniprofessionalism included learning of clinical skills, patient and ethics, everyday life in a ward, and communication. The clinical tutors have succeeded in integrating clinical and theoretical learning in a safe and challenging interprofessional learning environment in which students receive the necessary tutoring and learn from and about each other's profession while caring for, training and rehabilitating the patients. The interprofessional learning environment put pressure on the students who felt they were on fire when they had to explain their plans and choices to the other students as well as to the associate professors. And then there was one unintended outcome, which was that the interprofessional training unit was more cost effective than the conventional ward when we examined this in 2006, because the length of stay was shorter in the interprofessional training unit than it was in the conventional ward. We had assumed that the patient stay in the interprofessional training unit would be longer, because students would use more time to rehabilitate the patients than would the trained staff, so we were surprised. So why this short length of stay? One reason could be the interprofessional planning and coordination in the morning meeting, which means a minimum of wasted time for the patient, because all students know what to do, how to do it, and when to do it. Few types of patients, usually without comorbidity, means that the students very quickly can acquire basic knowledge regarding the care and rehabilitation of the patient in question, and therefore also within the first 2-3 days can learn how to handle the situation professionally and efficiently, with consequently relative shorter lengths of stay for the patient. So we try the students to use both analytic and non-analytic approaches in the clinical reasoning. Occupational therapy and physiotherapy students in both morning and evening shift provides patients the opportunity for training more hours, with consequently relative shorter lengths of stay for the patients. And I think that you all will find that these results are really good. But you could rightly ask, does it matter in the long term? Are the results long-lasting? And will the clinical interprofessional training unit make a difference for the whole hospital? The Swedish Medical Association conducts annually surveys of all newly graduated medical doctors. In an article written by Farsø and colleagues in 2007, is written that reports that medical doctors that during the education had been exposed to interprofessional education reported significantly better skills to cooperate with other professions than the fellow students from the other Swedish universities. And there was not found any difference in medically handling acute patients. I will now come with some reflections about tasks and challenges regarding starting up an interprofessional training unit. The steering group should take care of overall planning and include representatives from all stakeholders, for example, university, university college, Hochschule, hospital management, clinical ward, occupational and physiotherapy department for our case. The task group should include the same group except the hospital management. They do not need to be in the task group. And the project manager should be coordinator and preferable only report to one person, for example, the executive consultant or head nurse, not report to a group. It's too difficult, one person. When we talk about practical organization, there can easily be challenges and discussions between stakeholders. Syllabus is normally not alike in different universities and schools. The university is thinking about curriculum and the professor's workload, while the place for internship as a part of a normal ward is thinking of operation and patients. So you can say that both the university and the place for internship has to lift themselves up in what we call a helicopter perspective and say, yes, we want to do this. And instead of focusing on the obstacles, we will focus on being flexible and result-oriented. It is important that the ward where you want to start up interprofessional education has drive and energy, and this goes both for the management and for the staff. When you want to start up something new, you will have to give up old working methods, and this can be a challenge to many. Therefore, it is important that the management in the ward, in word and deed, radiates, yes, we have made this decision and we will stand up for it. Facilities for students must of course include that there is room and facilities so that they can work. In Holstebro, the students have their own office with more than 10 computers. Both the clinical tutors and the students must have admittance to computers many times during the day. They have to read the record and to write notes. All documentation is electronic, registration of care, training, rehabilitation, medicine and contact with other parts of the health system. We also have a conference room for the students and a coffee room where they can take breaks and eat. It is important with sufficient resources for clinical tutoring and preferable equality in hours the clinical tutors are in the ward. Because if we want to work in new ways where the physiotherapists and occupational therapists are closer affiliated to the ward where the patients are, then the clinical tutors ought to be the good role models. And then finally, it is important that there is sufficient backup from the rest of the ward, because the students' learning will be reduced if there's not enough staff present. Clinical tutors as role models. The clinical tutors have to be aware of their role. They have to discuss how best to create and maintain equality. By us, the clinical tutors in occupational therapy, physiotherapy and nursing takes turns to be responsible for the periods. And this means that they all can step in and manage different situations. Supervision on supervision is a good idea because it may be difficult to see your own actions and behavior. An external supervisor can help you with, so to say, putting up a mirror so that you maybe can see what in a given situation happened between you and the student. When we started up the interprofessional training unit, we, for example, discussed the meaning of physical placement in the interprofessional morning meeting. Should we sit beside or behind, or where should we sit? How could we best manage to get the students to communicate with each other instead of all the time looking and for what is my supervisor thinking right now? So we had some external supervision, and this is a drawing of what the supervisor saw when we told about it. There are some barriers when you want to work interprofessional. For example, stereotyping. Stereotypes are beliefs about characteristics, attitudes, and behavior of certain groups. You know those gynecologists, how they are. And the gynecologists, they know how you midwives are. Stereotypes is not only a bad time, it's also a good time because it helps us, it allows us to rely on experiences that we have had in the past, but it can also be dangerous because we put all in the same bottle, so to say. But one way of breaking down these stereotypes is by clinical placement in an interprofessional training unit. The upper picture I showed you before, and I also mentioned these conditions for intergroup contact, equality among the professions, equality in the situation, common goals, collaboration, support, This was written by Allport in 1954, and then in 98, Pettigrew added friendship potential. It's also therefore we have coffee room for our students so that they can be together and learn each other to know as persons, not only as professionals. It's the same for the clinical tutors and the teachers. It's important to have a friendship potential. It doesn't mean that we have to be together all the time, but also that we learn each other to know as human beings. Then there's also the perspectives. Here we have a physiotherapy student and a patient. And on the one side we have the clinical tutor from the interprofessional training unit, and on the other side we have the nurse from the ward. They are looking at the same situation, but they do not see the same. Maybe they do not see the same. I don't know if they see the same, because it might be that the nurse from the ward has a clinical focus on 80%, while the clinical tutor has an educational focus on 80%. And it's important to share these perspectives with each other so that we get a better understanding of why are we working as we are. When you start up and you have clinical tutors standing with their hands on their back and looking at what the student is doing, then the other staff could think, why don't they work? They can come and help us, we are busy. So it's important to share these perspectives. The learning takes place because the patient's needs define what to do and so on, and this will be published on the AVAC homepage. So I will go to the next picture, which is about surveillance, where the clinical tutor for the responsible for the period takes care of surveillance during the period. It's very, very important to survey what you are doing. Also to speak out to the students, what have you seen them do, how do you see them behave. And then it's, as I write in the last line, day 9, 45 minutes evaluation of the period. Because we learn so much from the students when we listen to them. This interview we have with them is both a reflection for the students, but it's also for us to learn from and to maybe make adjustments in the way we are working. References will come on the homepage. Thank you for listening.